Okay. Good morning, everybody. Nice to have you here. Thank you for the invitation. So my presentation today is on the anterior accessory saphenous vein. The first part of the presentation, I'm going to let you know a little bit about the anterior accessory saphenous vein. And later on, I'm going to talk about why this vein is important, why it should be treated. If you talk about the anatomy of the anterior accessory saphenous vein, it's one of the tributaries of the saphenofemoral junction. It's present in about 50% of cases. And the origin of the AASV is formed by extrafacial tributaries. How the segment of the AASV which is adjacent, that means the cranial to the saphenofemoral junction, is mostly interfacial. Now the AASV has its own saphenous compartment, what we call the saphenous eye, which can be clearly distinguished from the saphenous compartment of the GSV. And the upper third of the thigh, two saphenous eyes can often be distinguished, one of the GSV and one of the AASV. And the saphenous eye of the AASV is recognized by what is called the alignment sign. And this refers to the fact that the alignment of the AASV corresponds to the underlying femoral artery and the femoral vein. Very easy to understand on the ultrasound. Now the AASV usually joins the GSV between about 0.5 and 2 centimeters from the SFJ. In some rare cases, however, the AASV may actually have a separate junction with the common femoral vein, which results in what we call something like a double SFJ. Now, if the AASV is incompetent, it typically results in visible varicosities, which are seen coursing obliquely on the anterior side of the thigh to the lateral side of the knee and the lower leg. Now, how common is the AASV when we are actually doing surgery and venous ablation? In this paper of 2017, you will see that reflux into the GSV was present in 77% of patients. Reflux only into the AASV is present in about 10% of patients. And interestingly, reflux in both the AASV and the GSV was present in 11% of patients. So this is not something which is uncommon and should not be missed. You must do a good ultrasound. Now, there are different types of reflux into the AASV. You could have an incompetent terminal valve and a competent pre-terminal valve, so the reflux will only be into the AASV and not into the GSV. You could have an incompetent terminal and pre-terminal valve in which you could have reflux both into the AASV and the GSV. And there are various other different types of reflux into the AASV, as you can see here. As far as the clinical presentation is concerned, it's usually in the form of visible varicose veins on the anterolateral aspect of the thigh most commonly. Sometimes it can be present on the anteromedial aspect of the thigh, and in some cases, it can also be present below the knee, lateral to the knee, sometimes medial to the knee. How does a patient with AASV reflux present? Varices due to AASV reflux may be quite prominent, but surprisingly, very few patients have significant symptoms. Many patients are mainly worried about the cosmetic aspect of the ugly legs. It's rare for a patient who only has AASV reflux to have advanced venous disease. So usually it's between C2, C3. Rarely patients may present with a bulging mass in the groin due to an aneurysm of the proximal AASV, and this can be a bit of a complication, can lead to thrombosis here. How do you diagnose a reflux? Of course, Doppler ultrasound is mandatory. The diameter of the AASV is measured preferably about 5 centimeters from the SF junction and in the straight part of the vein. And a focal dilatation exceeding 20 millimeters of this vein is called an aneurysm. The treatment of an AASV is standard like you would treat any other vein. It could be surgery, it could be endovenous thermal ablation, it could be ultrasound-guided foam sclerotherapy, or it could be phlebectomy. Now, according to recommendations, it's advisable to ablate the AASV up to the point B, where the AASV joins the GSV. But come to think of it, the section of the vein between the point A to point B of the GSV is still refluxing. So if you ablate only the AASV to the point B, it is possible that the reflux which is coming in up to point B will now be directed to the pre-terminal valve, and then there would be reflux in the GSV later. So this is the point to be considered. Now the next part, why is the AASV important? For here, we must note the role of the AASV in recurrence of varicose veins after endovenous ablation. We know that it's commonly responsible for recurrence of after ablation of the GSV, and therefore it's very important that we should routinely look for the AASV actively during Doppler ultrasound. It's shown to be responsible for about 8 to 35% of cases of reflux, And in one series, it was responsible up to 43% of reflux. In the Rivata study, overall recurrence of 6.9% after EV years detected, and of this, 25% of cases were due to reflux in the AASV. Now, classical endovenous thermal ablation, we know we position the catheter tip about 2 centimeters distal to the SF junction, but here we leave a longer stump, and this longer stump which is there might lead to reflux into the ASV later. And therefore, nowadays, we prefer to do, in some centers, a flush thermal ablation with the SF junction, what we call laser crosectomy. A paper by Chris Raag well showed that if you do laser, which starts at the femoral level, flush, the reflux in the ASV is only in 1 in 120 patients, while if you do it below the epigastric vein, which we normally routinely do, it's as high as 6 to 120 patients, which is quite a lot. Now, is long-term ASV recurrence higher after laser ablation? 5-year randomized study comparing lasers with SF junction ligation. It was definitely shown that if you do ligation versus EVLA and you leave a longer stump, ASV reflux is higher. And similar results are seen even if you do RFA. So no real difference. ASV reflux occurs in both the cases. How to decrease the recurrence? Since ASV now we know is responsible for a significant number of recurrences, should we close all significant ASV at same time as ablation of GSV? Here, the topic given to me was 3 millimeters and larger. In my practice, if I see an ASV during GSV ablation, irrespective of the size, I will close it. But what is the evidence for prophylactic ablation? First of all, we are talking of a simultaneous ablation of an ASV which is not refluxing. Secondly, different people use different methods of treatment, laser, RFA, foam, whatever. And we really don't know whether this works. So now we have something called a synchronous study from Germany, which is prospectively studying this aspect. This is from the Department of Dermatology, University of Heidelberg. And what they are doing here, it's a multi-center, prospective, controlled clinical study for elective thermal ablation of a refluxing GSV. And what they do is randomize patients, those who will only ablate the GSV, those who will ablate the GSV and a non-refluxing ASV, and follow them up to 5 years. And then we'll see at the end of 5 years what the results are, whether we can prophylactically really close the ASV. So in conclusion, ladies and gentlemen, the ASV is an important saphenous trunk. Duplex ultrasound should be used in all cases to try and identify the ASV. The ASV is responsible for a significant number of cases after recurrence, after treatment of the GSV, but we do not as yet whether simultaneous treatment of a non-refluxing ASV will decrease recurrence. Thank you.